the Ebola fighters. And we are honored today to have one of the key warriors with us, Dr. Tom Frieden, Director of the CDC, where he's been running the show since June of 2009. He is a physician with training in internal medicine, infectious diseases, public health, and epidemiology. Dr. Frieden is known for his expertise in controlling both communicable and non-communicable diseases in the United States and worldwide. And of course, there's another reason that most of the media are here today, which he will be talking about. It's my pleasure to welcome Dr. Tom Frieden.
Thank you very much for being here, and thanks to the Atlanta Press Club for bringing us here together, and thanks to the media for covering public health issues. We view the media as an ally. We view the media as extremely important to the work that we do in public health, protecting the public. And that's what CDC's work is all about, working 24/7 to protect Americans from threats, whether they come from this country or anywhere in the world, whether they're infectious, environmental, or chronic, whether they're man-made and intentional or naturally occurring. Undoubtedly, in terms of health, Ebola is the story of the year. And it has been quite a year struggling with the world's first outbreak, world's first epidemic of Ebola. We've had outbreaks before, but we've never had an epidemic before, spreading widely through multiple countries, deeply into communities for many, many months, now actually more than a year of spread of Ebola in Guinea. So the challenges are enormous, and I really feel privileged to be able to represent and tell the story of the CDC staff, the CDC professionals who are so terrific at what they do in finding and stopping health threats and preventing them from spreading whenever possible. And we have here three who've spent time in the region, Dr. Neil Vora, who was in Liberia, Naomi Drexler in Guinea, and Dr. Jennifer McQuiston in Sierra Leone. So thank you for what you do. I've offered to our staff, we have now 170, actually today 180 staff in the field in West Africa. And we have regular communication with them. We have more than 700 people working on Ebola at any one time at CDC now. It is the largest global response in CDC history. And we are not just in the three countries where we are having impact not only at the national level, but out in the provinces and districts and counties and communities. But we're also in the surrounding areas to strengthen them in case, like Mali and Nigeria, which I'll talk more about in a moment, they have cases or individuals who get sick and may spread it there. But I offered to my staff if they'd like calls on the holiday, I'd do so. And one of the groups was a group of 4 women working in Bo, Sierra Leone. One of them was on her 3rd deployment to West Africa, each for a month. This was her 3rd time. She'd been both in Liberia and in Guinea. She has a 2-year-old child at home. The first time I met her, I was walking through, I do management by walking around whenever I can. I was walking through the Ebola area back in the spring and meeting all the folks and hearing the stories. And she had a screensaver of a beautiful child, and I said, so nice, and that was her young child. That was 6 months ago when the child was 18 months old. And she had next to her at that point an enormous suitcase, and it was the mobile lab components that she was bringing with her when she deployed the next day. This was her 3rd deployment. The team said they'd like to chat with me on Thanksgiving, so we had a nice chat. They had done amazing work. They were working 12, 14-hour days, including lots of time in protective equipment, which is hot and uncomfortable. They had upgraded their system using the latest technology to use a robotic extractor so that they could double the throughput. They had done 2,000 Ebola tests in 21 days, more than the rest of the laboratories in that whole country combined, more than the entire country of Liberia combined. These 4 women working out there in a rural area in Sierra Leone. And each night when they would leave the work, they would hear drumming, and the drumming was drumming of celebration of the survivors leaving the Ebola treatment units. Monday of this week, I lose track of the days sometimes because we work every day here at this point. I think that was 2 days ago. Monday of this week, they brought that same robotic extractor equipment purchased by the CDC Foundation and delivered it to a South African laboratory which was trying to do high-volume, high-quality testing in Freetown, Sierra Leone. And Monday it did 57 specimens, twice as many as they could do otherwise, and they may get up to 150, 200 specimens by the end of this week to begin addressing the challenges there. But really what's happening now in Ebola in West Africa is that we are transitioning from the very difficult work of breaking the cycle of exponential growth, and that cycle has been broken in Liberia, and we're working all out 24/7 with all of our resources to break it now in Sierra Leone. We've broken it already in Liberia, and Sierra Leone is the challenge. The next challenge, and quite frankly, the harder challenge, is getting to zero, identifying every case, tracing every chain of transmission, going into every community in each of these 3 countries to make sure that people with fever are appropriately evaluated, and if they might have Ebola, tested. And if they have Ebola, quickly isolated, cared for, their contacts identified, and every one of those contacts traced. To give you a sense of what that takes, in Nigeria, when a single patient from Liberia went there over the summer, we put 10 of CDC's top disease detectives onto the ground within 48 hours. In Nigeria, we had the benefit of a large CDC program, including the polio eradication program, which has been supported by Rotary International and others. We had trained over 100 Nigerian physicians to be disease detectives for polio. We took 40 of them and said, work on Ebola for a while. We had helped Nigeria establish an emergency operations center, which is the nerve center for effective deployment and response. And we said, please send your deputy director over to run the polio response, and they did. Over the next few weeks, they identified 899 contacts. They did 19,000 home visits. They identified 19 more cases, 2 clusters, one in Lagos, one in Port Harcourt. They built an Ebola treatment unit. They trained 2,000 health workers in how to care for Ebola. They screened over 100,000 exiting travelers from the airports. And at the end of the day, they stopped Ebola in Nigeria. The cluster was over from that import. We're right mid-response of that same type of response today in Mali. There was one case that came in, no secondary cases. The second case came in. There have been 7 secondary cases, 2 chains of transmission, more than 400 contacts traced. They now are not completely out of the woods, but it looks like that cluster may well be over. But they are still at great risk, because as long as there is any case of Ebola spreading in West Africa, not only are every community in these 3 countries at risk, but the countries around them and the world is at risk. The plain truth is, the only way to get to zero risk in the United States is to get to 0 cases in West Africa. And that's what we're working flat out to do now. It's going to be difficult. We have not seen Ebola act in this way before, not because the virus has changed. We've sequenced it. The genome is similar. It's a 19,000 antisense RNA-based genome. We understand some about it, but we have not seen it work in this context before. We have not seen it in urban areas where contact tracing becomes exponentially more difficult. We have not seen it go through 20 generations of spread. We like to stop an outbreak in 2, 3, at most 5 generations of spread. Here we are a year later still having cases. And the challenges are very different in each of the three countries and in places within the three countries. So for example, in Liberia, we now have outbreaks all over the country. Individuals from the capital city, it changed. First, it was in the rural area. Then it got to the capital city because people came there for care. And then we knew things were different when we were able to control it in the rural area. And there were no cases in the Ebola treatment unit there. And then people started coming from the capital city to be hospitalized in the rural area instead of the other way around. And to all over the country, people fled or returned. And that kind of challenge has led us to work with the Liberian government and with our international partners and U.S. government partners to create what we call the RITE strategy, R-I-T-E, Rapid Isolation and Treatment of Ebola. And we have sent teams out about 20 times, anytime there's a flare-up anywhere in the country. And what we have learned very clearly is that time is of the essence, or as one of our staff said, in this case, it is not speed that kills, but the lack of speed that kills. Because what we find is if we can get there promptly, we can stop it. For example, one of our RITE teams went into a community where they had heard rumor of a case. They went to the end of the road. At the end of the road, they started hiking. They hiked 4 hours in. After 4 hours of hiking, they came upon a village, a community of 20,000 people. They were clustered around a diamond mine, and there was an outbreak of Ebola there. But they were able to identify it, to isolate patients, and to stop it. In another community in Tonkolili in Sierra Leone, we had a group that went in, and to get to the community, they had to take a jeep ride over a rutted road. Then they had to take a hike through a forested area. Then they had to take a canoe ride over in a crocodile-infested river. I kid you not. And then they had to enter a village not knowing the kind of resistance that they might have because of the fear of Ebola. But it's the kind of work CDC staff do 24/7 in these countries and around the world. But the challenges in West Africa go beyond Ebola, because Ebola has, in many communities, shut their healthcare system. I was in one hospital which usually did 125 emergency cesarean sections per month. Now, unlike in our country where there are too many cesarean sections for primary cesareans, there it's only if the woman is going to die, the baby is going to die, there's terrible bleeding, there's a terrible problem. Well, in the previous month, they had done 25, and it was 100 miles to the nearest other place that could do a cesarean section. So 100 women who needed emergency cesarean sections hadn't gotten them there. And it goes down the line with the healthcare system: malaria treatment, vaccination, treatment of pneumonia. These systems are not in place, and it's important that they get in place not just because people are dying for the lack of those services, but also because until we have that up and running, we won't be diagnosing Ebola promptly, isolating patients and getting them effectively cared for. But it's not just health. It's their entire society and economy that's in crisis now. And I spoke with the head of GE Africa, who commented that it's not just West Africa. For many parts of Africa, they're seeing a downturn in investor confidence and challenges in the economy. And this is a reflection of how interrelated our world is. Sometimes in inappropriate ways, people may not understand the geography of Africa. There was a very nice news piece that pointed out that Europe is closer to West Africa than Ethiopia by flying time. So there's really a lack of understanding sometimes of how our world is constructed. But our work in Africa won't be done until we've put out the last ember, until we've extinguished the last spark. And as long as that goes on, we're focusing on the U.S. as well. We have to strengthen at the homeland. Our top priority is protecting Americans from threats. So we've put into place a multi-level system to protect Americans. First, stopping it at the source in West Africa. Second, screening travelers leaving these 3 countries to see if they have fever. We've screened, we just published today, I believe, experience of the first few months doing that. 80,000 travelers screened, 12,000 of the 80,000 were coming to the U.S. Of those 80,000, about 1%, about 0.1%, about 80 had fever and were denied boarding. So getting people not to board airplanes coming to the U.S. is one key thing. When people come to the U.S., we work with Border Protection, Homeland Security to funnel people to 5 airports, including here at Hartsfield. At each of those airports, all of the travelers returning from those countries are asked certain questions, and their temperature is taken, and if there's any concern, we're there 24/7 to do tertiary screening. Once they leave into the community, we provide to the health department of their state their contact information. We provide to them a package with a thermometer so that if any of them get fever, and some of them have, they call a hotline and they're safely transported to a hospital where they can be safely cared for. That's some of the things that we're doing to protect us here in the homeland. Obviously, we've worked with hospitals all around the U.S. to improve preparedness so that they can do what they need to do so that anytime there's someone with suspected Ebola, that person will be promptly isolated, effectively cared for, and treated while minimizing risk to health professionals. Finally, I'd like to end with a discussion of where this is in the broader picture. In the broader picture, Ebola is a symptom of a disease. And the disease the Ebola epidemic is a symptom of a disease. And that disease is a lack of preparedness for infectious disease threats in countries all around the world. And we are only as safe as the weakest link. We only have the visibility of the blindest spot in the world. This was a blind spot in West Africa. We didn't have surveillance systems up and running. We didn't have disease detectives. And we know that whether it's resistant organisms or intentionally created organisms or emerging organisms, there is the risk of infectious disease threats. And that risk will not be minimized for us until it's minimized for other countries. We are truly interconnected in ways that Ebola has reminded us, but SARS reminded us, and MERS reminded us. And just imagine what a different world it would be today if we had recognized HIV decades before we did. And that's why our key priority as the nation's prevention agency is to put into place the global health security capacities that are lacking now. It's a jargony term, global health security. It's a very concrete set of things that will be different. And I'm very encouraged by the bill that was published last night. We don't know that it will finally get approved, but it includes substantial resources to make Americans safer by building the core things that we need around the world. We need laboratories. So if something like Ebola breaks out, it's found in days, not weeks, not months. We need surveillance systems, early warning systems, fire alarms, so that if there's a cluster of SARS or MERS or Ebola or the next big thing, we find it before too many people have died. We need trained disease detectives. We have fantastic CDC staff. We've had 600 staff go to West Africa already. And that's a tribute to the commitment of CDC staff. And what we will do, and what we have been doing, is to multiply our forces so that there are thousands and tens of thousands of disease detectives around the world who can do this work without our being there, because that's our goal. And we want to make sure that there are emergency response units and emergency operations centers all over where there may be an emergency response. And we've already worked now with all of the surrounding countries. We have a lot more work to do with them, but they're beginning to get ready. And that's what we think we can do with the resources available. We have many months to go in this response. We don't know with certainty that we can put it back in the box. We don't know with certainty that we can make Ebola completely go away, but we do know with certainty that we are going to do everything in our power to make that happen. And we have a degree of confidence that with the commitment we're seeing from countries, with the funding that Congress is considering now, with the expertise of CDC's staff and the commitment of our staff, and with the partnerships that we have with the host country governments, with communities, with international organizations, with NGOs like MSF that's done such terrific work, we are optimistic about the ability to stop Ebola in West Africa. Thank you very much.
Thank you, Dr. Frieden. We have a few minutes for questions. Maria.
Good. Obviously, CDC being in Atlanta has been a real crown jewel for the city. Atlanta's been described as a center, a major center for global health. Could you talk about how you view the role of Atlanta, your relationship, the CDC's relationship, and what the city can do, or city leaders and organizations do, to make CDC stronger going forward?
There's so many terrific organizations here in Atlanta. There's CARE, there's the Carter Center, there's a vibrant business community, a journalistic community that you represent. So it's a great home for us. We are, as you may know, the largest federal agency headquartered outside of the Washington, D.C. area. Sometimes we feel that we're a little bit out of sight, out of mind when it comes to D.C. and D.C. politics. And although sometimes that can be good, when it comes time to allocate budgets, it's not necessarily a good thing. So people like Oz Nelson, who's here today, have done such a phenomenal job educating people in Washington about the vital role of CDC keeping Americans safe. And Atlanta is an important base for us. We have wonderful relationships with many of the universities. We have wonderful relationships with many of the NGOs here and the business community. It's a comfortable place for us to work from and to build on, and we very much value the partnerships we have.
What does CDC need in Atlanta to continue to be healthy and thrive?
Better traffic? I don't know.
Maria's was the one report in the Business Chronicle. For other questioners, if you would just stand and just say who you're with.
Oh, I'm sorry.
So,
Except for a broken foot, I'd stand. I'm Tom Johnson. What do you lose sleep over each night?
Well, the truth is I usually sleep well. So I don't lose sleep each night. And I usually sleep well because of the phenomenal quality of CDC staff. It is just inspiring to work with the staff we have. I had breakfast with 8 or 10 of the recently returned staff who came back from West Africa. Each was telling me about their work and what they had done and the contribution they had made and their commitment to do whatever they can to stop the outbreak there. So one of the things that helps me sleep so well is how phenomenally effective our staff are. They're not only dedicated, they're not only smart, they're not only knowledgeable, but they're strategic about what we need to do to protect Americans. Some of the things that do worry me are, will we have the resources? Will we have the ability to work effectively in these countries? I worry about some of the areas where, not in Ebola, well, some of the areas in Guinea where there's been civic unrest and violence against responders. That's a real concern. We're working still flat out on polio, and if you just think of where we are in polio, Africa is very close to being polio-free. It's not there yet, but it's closer than it's ever been. And those 40 people who we redeployed to Ebola, they were part of a big group that CDC and all of our global partners have surged into the ground in Nigeria, and they're now very close to eliminating polio. But we've got so much violence in Pakistan, will we be able to get rid of it? So I worry about the things that aren't in our control.
back in the back.
Dr. Frieden, Johnny Clark with Associated Press Television News. It's quite a coincidence that you're speaking here today, but could you tell me what ran through your mind when you first learned that Time Magazine picked Ebola fighters as their persons of the year? Quite an accomplishment.
I just think there's so many people who've done such phenomenal work on Ebola control. I want them to be recognized, and that means people on the front lines in West Africa. That means some of the NGOs, particularly MSF, which has been right over and over again and in the right place at the right time over and over again. and of course our own staff. We've had 600 people in the field in West Africa. We have 180 people in the field today in West Africa. We have more than 700 people working on Ebola at CDC, and they've been working around the clock, month after month after month. The person who's our incident manager asked me the day before Thanksgiving, and she's been incident manager now for 4 months, who signs my leave slips, because I may want to take a day of leave. The staff there have all been working every single day, 7 days a week, long hours. So it's just great to see the recognition of the phenomenal folks that we have at CDC.
Hi, Kathy Scott, Ray Scott Communications. I wanted to ask you, you all have, CDC is a little bit off of Ebola, but it does go to mental health, identified electronic aggression as teen violence. Suicide rates are up. What kind of efforts are made in those kinds of areas where it probably is more of an effect on America as opposed to Ebola?
We do many things at once at CDC, and it is the Centers for Disease Control and Prevention. We have a Center for Injury Prevention and Control. I met with them yesterday. They are looking at a wide range of issues, violence and suicide. We look for the things that we know work to scale those up. We look for bearing witness on what the problems are to bring information out into the public. And we look for pilot projects of where we don't know what's going to work, try something, rigorously analyze it, then if it works, we can scale it up. They're working on a series of programs, for example, to reduce senior falls. It's a terrible problem in our society, often results in a lack of independence, and there are evidence-based interventions that will reduce the likelihood that seniors will fall. So as the nation's prevention agency, we look for the winnable battles, the things that either we know now that we need to scale up, or big problems that we can shed a light on and then rigorously try to figure out how to address it.
In the white shirt.
Ray Henry with the AP. What can you tell us about the patient who was taken to Emory being monitored for Ebola? Can you give us any sort of update about what you're seeing in that case?
I'd have to refer you to Emory. We really do respect patient confidentiality, but this is not someone who has Ebola. This is someone who's being given preventive intervention, or considered to be given preventive interventions because of the possibility that they may have been exposed.
Dr. Frieden, Jeff Burton, Fox News Channel. Can you talk about where we are as far as drug treatment protocols, possible immunizations, and those sorts of things in the future prevention of Ebola?
So there are three really important areas for innovation in Ebola. The first is point-of-care diagnosis. The second is treatment, and the third is vaccination, and we're very active in all three. I'm very excited about some of the diagnostic tests that seem to be working out quite well. We've offered to private companies that have promising products to come to our lab. We'll make lab space for them to set up and optimize their assays. We have at least one or two companies that we think are pretty far along, and we may have a point-of-care test for Ebola within the next few months. Can't promise it, but it would make a big difference. Think about that hike, canoe ride, and Jeep travel, which had to go in both directions, 8 hours to bring samples in. If you had a test strip in your pocket that could test in 20 minutes the results, that would be very, very important as a tool for disease fighting. And I think we'll see that within the next few months. So that's...
Can you name the companies?
No.
Is one of them the North Carolina?
Second, there are treatments, and there are many people looking at different treatments. Some are promising. None of them are proven. None of them are available in quantity. And we're also looking at routine medical care, fluid resuscitation, electrolyte balance, antidiarrheal agents. These are things that may well save lives, and we've got them today, but we need to know to deploy them well and quickly. And the third is a vaccine, and we've actually have very active planning for a vaccine trial in Sierra Leone. I anticipate that getting started in the next 1 to 2 months. We have at least 2 promising vaccines in animal models. We have no idea if they will work in people, but we're hopeful that we'll be able to start a trial on that and have an answer sometime in 2015 of whether these vaccines work.
Betsy.
Betsy McKay, Wall Street Journal. So you were talking about the need to get to zero. This outbreak can have different
So the risk here is the risk of Ebola becoming endemic. That's the risk we have to fight against. Endemic means it continues, even if only at a low rate, throughout these three countries. Because if it becomes endemic, then there is a high likelihood that it will spread to other countries around Africa, and that we will have to be dealing with it for years to come. And that's why we have to go to a real emphasis on getting to zero, where not a single case is acceptable. And to do that, we have to scale up district, county, prefecture-based public health teams. CDC has already put teams out to most of the affected counties. We have staff in remote areas helping to operate public health response teams there. We have to shore up infection control through the healthcare system as it reopens. And Guinea is kind of a cautionary tale, because they did a good job with a lot of the aspects of their control, but because they had resistance in the forest area, it came back. And they've faced kind of an Ebola complacency or Ebola fatigue, which is understandable. If you're a doctor or a nurse and you're treating hundreds of people and none of them have Ebola, it's easy to forget that the next one might have Ebola. But we're now seeing healthcare worker cases in Guinea for the first time without known chains of transmission. So this is of great concern, and it's why the funding from Congress is so critically important, so we can surge the public health response down into the local level and identify each case early, track every contact, and make sure people are promptly isolated. We can stop Ebola, but whether or not we do so will depend on how quickly, how meticulously, and how widespread our response is. But I'm very encouraged by the kind of commitment we have from each of the countries and from the global community as well. It's not just the U.S. coming in. Lots of global partners are coming in as well.
Yes, Mark Mosley with the international NGO MAP International. I was wondering if you could tell us a little bit about the CDC is doing to build national capacity within the African countries themselves for the next Ebola class out.
We'd have to be here for the next hour if I give you a full answer there, but we do a lot. One is to train people. So we have epidemiology training programs. We will be training thousands or tens of thousands of people within country. We have very successful models where we train within country, and 80% of the trainees at the highest level stay in country working in public health leadership positions. And we're going to expand that down to the local and lower levels. We'll be building laboratory networks, helping establish surveillance systems, helping to put in emergency operations centers, helping to do drills and preparedness. One of the things we've learned about preparedness in this country and around the world is the way it works best is not to have something shrink-wrapped in the cupboard in case there's an emergency, but to have an everyday system that's robust and can be scaled up in the case of an emergency, and that's what we'll be helping them to implement.
Dr. Frieden, Michelle Alloy with WABE. You talked about an Ebola complacency. Admittedly, you're talking about Guinea, but as this is increasingly not on the forefront of people's mind now, is there a fear that money will not be coming in as much as it should be as this as it continues to spread right now?
I'm confident that Ebola has been really a moment when the world has taken notice of the importance of strengthening the public health infrastructure in the U.S. and around the world, because it's brought home like nothing else in recent years just how vulnerable we all are if we don't strengthen those basic early warning systems and rapid response systems.
Okay, we have time for one more question, and then Dr. Frieden will spend a few minutes with the press, but he's on a pretty tight schedule.
I'm Carla Barnes with Kennesaw State University. One of my questions, when you were talking about disease detectives, what are the kind of educational backgrounds of these individuals, and what are the things you're seeing from the educational side that they're the components you have to build that kind of robust system of people going out in the world? What can we do to prepare them to do this kind of work?
At the CDC, we run something called the Epidemic Intelligence Service, or EIS. Sorry. At the CDC, we run the EIS, and we have doctors, PhDs, veterinarians, dentists. I'm probably leaving out a few advanced degree folks who are in the EIS program. When we work in low and middle income countries, We can work with doctors, with public health trained people, and we think of kind of a pyramid of skills. At the apex, maybe a physician who's then gotten advanced training in epidemiology, what we call field epidemiology, which is frankly how to find and stop an outbreak. At a mid-level below that are the people who might be at the district or provincial level. They need to know how to identify a disease cluster and respond to it. And at the base level on the front lines are people who need to report. And that connection between the healthcare system and the public health system is so critical to stop Ebola, but it's also critical for so many of the other things we do, not just in vaccination programs and reducing drug resistance and reducing hospital-acquired infections, but also improving things like the treatment of high blood pressure, which are going to save lots of lives. And that kind of quality work at the level of the intersection between the community and the healthcare system, between the public health system and the healthcare system and the community, that's the crux of what we need to get right to stop Ebola. And by doing that, we'll also have put into place a system that will make these countries and the U.S. a safer and healthier place. So thank you all very much.